So when I started my studies here 20 years ago, I came with a purpose. I wanted to make a difference for those who are vulnerable in our society, and I wanted to do it as a medical professional. The rest of my course was uncharted. So I began trying to learn as much as I could. And what I started focusing on, or the most interesting course I actually took, was something called medical geography. It was an interesting course because it got me to help understand how the way we start perceiving our own health, but also the way we deliver our healthcare in our society, is often influenced by our historical and societal perspectives, but also by the political context of the day. But it was also this train of thought that helped me starting to realize that perhaps the most vulnerable population in our society today are those of the elderly. And you say, well, the elderly, really? I would have thought of a different population. But I'll tell you this. The elderly actually have some disadvantages in our society today because we are not a society that tends to look forward to aging. In fact, we have whole industries that are now geared towards the anti-aging movement. But here's the real story. If we were born in 1900 in Canada, our life expectancy was only 51 years of age. But today, or perhaps the greatest accomplishment of the 20th century, was the fact that we almost doubled our life expectancy, so that today, our life expectancy is around 80 years of age. So while many people will think of aging as a disease, I actually think of it as a triumph and something we really should celebrate in particular. But there are a lot of people who are getting worried. Our policy makers and our bean counters are worried because they're saying, well, wait a minute, our population's aging faster than ever before, and is our healthcare system going to be sustainable to meet the needs of our aging population? So let me give you some facts to help put things into context. If you actually look at our population in Canada today, 16.1% of our population are 65 and better, as I like to say. And so, but we also know that this 16.1% of the population, they're set to double in numbers from 5 million to over 10 million in the next 20 years. And those of us who are 85 and older, or 85 and better, are set to quadruple in the next 20 years. So you can imagine that people are getting worried, especially when this small sliver of our population today actually represents 50% of our current spending on health and social care services. So let me put this in perspective in terms of the realm of our hospitals right now. When we look at all the hospitalizations that occur in Canada today, we know that 42% of our hospitalizations are accounted for by that small percentage of our population that's 65 and better. Yet we also know that because older people tend to stay longer in hospital than younger people, mainly because the people who are hospitalized might have complex health and social care issues, they actually end up accounting for 59% or almost 60% of our overall hospital days. And so you can imagine that by the time I became well entrenched into my medical training, me and my colleagues actually believe that, well, in Canada, I think the plan is that when I hit 65, I am supposed to sell my house and go live in a hospital, right? Right? Because that's what older people do. They go live in hospitals and terrorize young doctors and nurses all day long, right? Well, again, this is how I was big and wrong, because I started saying, well, wait a minute, but I know about my aunt and my uncle and my grandparent, and they're doing things other than hanging out in hospitals. And in fact, here's the good news, that if we actually make it to 65 in our society, and the good news today is most of us will, you actually get 20 years of life expectancy ahead of you, and the majority of those years are going to be in relatively good health, not hanging out in the hospital. But we know that there's actually a small subset of our older population in particular, in terms of all our older users of healthcare. In fact, there's about 1 in 10 older users of healthcare who actually account for 60% of all of our healthcare spending amongst older adults. And this is because these older users of healthcare tend to be suffering from what I call the Bermuda Triangle kind of aging, for example. What do I mean? Well, there's 3 points in that triangle, and here are the points. Number one, these older individuals tend to be struggling with multiple chronic health issues. So they may have heart disease, they may have arthritis, they may have had a stroke, or may have lung problems. Point number 2 is these individuals tend to be struggling with their independence by basically trying to do their activities of daily living on a daily basis. Now that's a fancy term. And the way I teach my medical students to remember your activities of daily living are the 6 things you probably did in this order this morning. Probably transferred from a lying to a standing position. You probably walked over to the bathroom. You probably toileted yourself, dressed yourself, and then you ate something, right? Those are your basic activities of daily living. And we know these individuals struggle to do these tasks on a daily basis just to stay independent at home. And then the third aspect that rounds out, or, well, points out that Bermuda Triangle is social frailty. What do I mean by that? Well, compared to 50 years ago, we're less likely to be living in intergenerational households or intergenerational communities. And we know, in fact, that older adults tell us that 27% of them don't have someone close at hand who could actually help them with a basic task like getting a prescription filled. So we have more of these people in particular who are leading socially isolated lives, struggling with multiple health issues, and struggling with just trying to stay independent at home. So now you imagine that these people, being the greatest users of our health care, also end up being the majority of the people who are stuck in hospital every single day. In fact, right now, on this day in particular, we have 7,500 Canadians, mostly older adults, who are actually stuck in hospital. They can't even go home, and they want to go home. They want to leave the hospital. But we don't actually have the right mix of home and community care services. We don't have the right rehab services, the right number of nursing home beds, those services that can help them leave the hospital. So the sad part is we then tend to blame them and say, why are you still in hospital? Why are you here? And we call them pejorative terms like bed blockers, other things like that. But these are people who want to go home. And the problem is if we don't actually have the right mix of services, well, then that's our problem. But why did we have that problem? Again, thinking of that historical, that geographical perspective. Well, 50 years ago when we created Medicare in Canada, the thing that we all hold near and dear to our heart, the average Canadian was 27 years of age. Right? So if you're 27, if you're a community of 27-year-olds, and you're thinking, well, what do I want to have in my universal healthcare system? Well, we want to have hospitals and we want to have doctors, but we wouldn't be thinking about home care. We wouldn't think about medication access or pharmacare. We wouldn't think about nursing home care. In fact, all of those things happen to be afterthoughts, and they're not enshrined in our Canada Health Act, so we're not obligated to provide them in sufficient ways as well. And so while we blame the elderly for the ills of our healthcare system, this bad thinking or this bad planning 50 years ago means that currently we actually spend $2.4 billion each and every year just on the costs of these people waiting to try and get back to their own homes when there are much cheaper and more reasonable forms of care that we could have available. So let me put a human face on this for you. And I want to tell you the story of my patient, Mr. W. Mr. W in particular was an individual that I actually met when he was 100 years of age. Now, Mr. W, he was born in Krakow, Poland. He led the most incredible life, and I wish I could spend the whole day telling you his stories. But, he actually trained as an engineer and an architect in Poland, and he was actually one of the key people who actually oversaw the rebuilding of Warsaw after the war. He eventually emigrated to Canada like so many of our family members and parents, and maybe ourselves actually did. And he actually established himself as an architect in Montreal and Toronto. And he used to joke with me that he only actually ever planned to live till he was 86 because that's how much money he saved for. But I actually met him when he was 100, right? And Mr. W was struggling with his independence by the time he was 100 in particular, because he was suffering from that Bermuda Triangle. He had chronic lung and heart issues. He had problems with arthritis and pain. So it was hard for him to get around, and he needed the help of home care attendants to get bathed and dressed in particular. Now, he had married, but his wife predeceased him by about 30 years, and he had a son who wasn't living in Toronto, so he was socially frail. But he was really charming. And that's the secret to aging, ladies and gentlemen, being charming. Because at the age of 100, Mr. W acquired a girlfriend, Jean, who was 30 years his junior. And Jean was Mr. W's angel. He always called her angel, his angel. And Jean was also his legs, because as he became increasingly homebound, as he couldn't get out of his home anymore, Jean would help him get his medications and his groceries to help him stay independent in his one-bedroom apartment in downtown Toronto. But the one thing Jean couldn't do for him was bring healthcare to him. In fact, he couldn't get out to see a family doctor anymore. So the only way that he would deal with his health issues is that when they flared up and became worse enough, he would call the ambulance and he'd go to the hospital, like so many of these frail Canadians. And in fact, I met him in 2010, 2 weeks being back in Canada as a physician. 2 weeks, and there he was for his 7th hospitalization of 2010 in particular. So now you imagine that Mr. W, and when he got sick, just in the preceding days, he actually developed a pneumonia. William Oster used to call that the old man's best friend. And this actually took this functional older individual And it actually led him to, who was struggling with his independence at home, to be coming to the hospital, because when he developed that pneumonia, he started struggling. As you know, we all get weak whenever we feel sick. And so he actually lost his ability to do his transfers as easily, going from a sitting to a standing position. And he actually had a fall at home. In fact, 50% of older patients who present to our hospitals actually have a loss of one of those ADLs in the preceding days of presenting to a hospital. And so, of course, Mr. W's son, who was worried about his father, decided to call the ambulance, and so his father went to our hospital on a Friday night. Of course, the time when we staff up and make sure we have extra doctors and nurses to help all of our older patients on the weekend. But Mr. W entered our hospital, which unfortunately hospitals all around the world end up being hostile environments because we created them for much younger people with single issues at a time, not complex older people like him. And the problem is that our hospitals tend to be hostile and depersonalizing environments in particular. And the challenge is because I don't know how many of you live your life according to the regimen of the hospital, but you might have to get used to it, because we serve breakfast at 7, we have lunch at 12, and you have dinner at 5. And if you don't eat it at those times, your food might get cold, okay? We also make sure that so that me and my colleagues can look at your blood work by 8 a.m. in the morning, we actually have a protocol that says we can wake you up at 4 and start poking you for blood work. How many of you were up at 4 a.m. ready to get your blood work to be taken today, right? And then what we end up doing is, well, I don't see any of you actually wearing the latest fashion at our hospitals in Canada. The hospital gown, you know, the one that flaps open at the back there? Well, that's what we strip you out of your clothes, so it's kind of hard for you to express your identity when you're wearing these clothes. And then all of a sudden, we take away that aspect of you, and then, Mr. W had a very long and complicated Polish name, so instead of taking the time, because we're so busy, to get to know it, we might just call him honey, dear, sweetheart. We might add an extra touch, by starting to pat him on the head and say, you're really cute, aren't you, right? How would you like to have that happen to you at the age of 100 in particular, or whatever age you're at for that matter in particular? And then the issue that we have in our hospitals is they tend to, the biggest piece of furniture you have in your room tends to be a bed, right? And so what are you going to do when you're feeling weak and not so well? Well, you're just going to go to bed. It's what we've always been programmed to do ever since we were young. But for older adults, every single day that you're in bed, you lose percentage points of your bone and muscle mass. Actually, that term move it or lose it, it's true. You should stay mobile, otherwise you're going to lose your function. In fact, every day of bed rest that an older person has in a bed, 5% of your function is what you're going to lose. So you can imagine that this is why Mr. W went from Friday morning being able to walk around his house with his walker to actually, by Monday morning, 48 hours later, he actually was a 2-person assist, meaning 2 people need to lift him around just so he could go to the bathroom in particular. And then the challenge is that when we actually have people in our hospitals, we do things. You have an increased risk of not getting the amount of food and drink that you need because we're doing all these procedures, so you might actually not even get the calories you need. We also know that with these older patients who tend to get hospitalized, they may have a higher chance of actually having an underlying thing like a dementia, and so this can actually increase their risk of something called delirium or an acute confusional state. And then, adding to all of this, we might actually give them extra medications, things to try and help them out. And the problem with all of these extra things is that you just need to be on 4 medications to have a guaranteed drug-drug interaction. Well, Mr. W is already on 12 medications, so you can imagine those extra medications we put him on, those extra procedures we do can lead to negative consequences, or a fancy term we like to call iatrogenic illness, things that we cause in the course of trying to actually help people. So you can see that hospitals can actually be really dangerous places, especially for older people. And in fact, the challenges with this is that it can actually lead to, I don't think any of you were smiling thinking about your next trip to the hospital now, so it can be a bit of a demoralizing experience. You remember all those chances that you could lose additional function? Well, you could lose additional function, and then the problem is that we actually have a recipe for creating dysfunctional older people. In fact, we now know that many people say that our hospitals are unprepared for meeting the needs of an aging population in particular, and that we need to change things around. So my colleagues and I got together around Mr. W's hospitalization, and we said we need to do things differently. We need to think about how we could actually change that recipe and make sure that it never happens again, or we try and minimize the number of times that that recipe actually works out. So we came together and we formed what we called our Acute Care for Elders strategy. We said, what can we as doctors, nurses, social workers, and therapists do to re-engineer the way we provide care so that we can help people like Mr. W? So we started saying, well, wait a minute, it's not just what we do in the hospital, but we need to get together with our community partners and develop services so that we can actually take care to people like Mr. W in their own homes through house calls. We can allow people to die in their homes. We can do things to support caregivers, but we can also help the majority of our population learn what they need to do to stay healthy and well so that they can stay independent as well. We also make sure that for those older patients, like Mr. W, who ended up having to come to the hospital, we wanted to make sure that they could actually have the support they needed. So we screen every older adult to identify that 10% of highest risk users, and then what we do is we make sure that they have specialized nurses called GEM nurses, or geriatric emergency management nurses, to help them get the care that they actually need, and to tailor that care to hopefully even avoid them getting admitted to hospital, but maybe actually going back home. Or if they come into hospital, how do we make sure that their care is along a good protocol so that they have the right care by the right teams? We make sure that we have actually geriatricized their order sets so they don't have those harmful medications that can cause problems. We actively mobilize our patients, and we make sure we try and do everything we can to minimize the harm during their stay. And then finally, what we've done is we've created a range of outpatient services as well that we can activate to help our older patients, and in particular, all of this forms a continuum of care in particular. It's our way of re-engineering the care that we provide so that we can make sure that our older patients are provided with the support they need, but also that our staff are empowered to provide the care that they want to provide to make sure that these older persons aren't stuck in hospital and they're more likely to return to their home. So, is it working? Are we actually having a positive impact? Well, it sounds pretty good, but we're really proud to know that 5 years on, we're actually seeing a real difference with the care that we provide. And this is the good news. This is the reason why we can start smiling once again, is because what we've seen in downtown Toronto alone is that our population has actually doubled over the last 10 years. And in fact, in the last 5 years alone, we've actually seen 53% more older patients coming through our hospital. It's our coming of age, if you will. But at the same time, by re-engineering the care we provided, we've been able to lower the length of stays of older people in our hospital by 26%. And we've actually reduced the risk of those individuals being readmitted to our hospital within 30 days by 14% as well. Also, the care that we provide is not just more efficient, but we've made sure it can be safer and healthier for our patients. So we've actually made sure that your chance of getting a urinary catheter cut by 50%, your chance of falling in our hospitals is down by 66%, and your chance of getting a pressure ulcer is down by 93% because we're actively mobilizing our patients and doing less things to cause harm. So our patients are giving us a big thumbs up. In fact, 97% of them are really thrilled with the care we're providing. And for those bean counters and those people who are really worried that our healthcare will not be sustainable with 50% or a doubling of our population over the next 20 years, we actually saved in 1 year alone $6.7 million. So Mr. W in particular, that was the best news because he actually got to go home. And he got his wish to stay at home for 4 more years. And while he ended up in hospital 7 times in 2010, in the next 4 years, he only went to hospital 3 times in total. And he actually passed away about a year ago, and I got to see him right before he passed away, and he held my hand, and he said, "Thank you so much for giving me my independence and allowing me to remain at home. You gave me my wish, and thank you. And I know you and your team are helping so many others do this. And I know you're going to be asked by many others to help other hospitals across the country and beyond do this." And of course, Mr. W's prediction came true because 6 months ago, we got a phone call from 2 of our Ministry of Health federally funded agencies, one called the Canadian Foundation for Healthcare Improvement, the other agency called TVN, or Canada's Frailty Network, which is based out of Kingston, Ontario. And they said, "We're going to give you $1 million because we know people are calling you and saying, we want to have this care across Canada." And so we're actually going to be starting a collaborative, a coalition of the willing, where we're going to allow lots of hospitals across the country and beyond to actually start implementing our ACE model of care. So my wish for 20 years from now, well, I don't know what the course is. It's a bit uncharted, but I'm hoping that 20 years from now, this care will be the care that every older Canadian and everybody who's old can receive across the world. But I'm also hoping that 20 years from now, we see aging as a triumph and not as a disease. And I'm hoping that Canada will be seen by that point as the best country to grow up and grow old in. Thank you very much for listening.